I'm making a presentation from Uganda prisons. I think it's the only one from prison, so you better keep sharp. I'm going to make this in the 10 minutes also, which I'll be done, don't worry. I'll go through a few headings, introduction, some considerations that you make while making programs for the prisons, HCS strategies that we've done in the prisons, the linkage to care, monitoring, treatment, quality assurance, M&E challenges, and way forward. Well, just like in most areas, the prisons have been largely neglected, and most diseases, especially HIV and TB, are disproportionately high as compared to national figures. As you can see in Uganda, among prisoners, HIV prevalence is about 15%, and among staff of the prison service, it's about 12%, as compared to the national average of 7.3%. And unfortunately, a total of 45 out of 249 prisons are the only ones that can actually carry out HTA services, which is very unfortunate and part of the reasons why most people don't know and they continue to engage in sex relations and transmissions. ART is only accessed at 10 facilities. These are the accredited facilities within the prisons. And under considerations, the Uganda prisons population is very mobile, just like I think all other prisons. People are moving between the prison and the community most of the time. And the annual turnover is 100,000 prisoners per year that have gone through the prison, from community prison and back to the community. And on average, you have a population of about 50,000 at any one time in the prison. And most of these movements are unscheduled. For example, people go to court and they get bail and they don't come back. So if you're doing a program with them, then it's cut short suddenly. Sometimes it's movement between prisons. People are transferred between prisons for various reasons. Part of them are political, others are due to security. So there's no appointment. They are sudden, a vehicle comes and picks a number of prisoners, and some of those are your clients. Oh, sorry. And then the other consideration to make is the security, that a prison is a security institution. And because it's a security institution, it's very difficult for the community-based healthcare services to access a prison and provide care. That means that for you to provide care to prisoners and staff, you need to have the care introduced inside the prison. Now, what are some of the HS strategies that we have undertaken in Uganda? We've done on-entry medical screening for staff and prisoners. Staff are normally recruited from the general community. They undergo a screening before the training starts. And unfortunately, in Uganda, if you are found with TB or HIV, right now, you will be stopped from undergoing the training because you may not be able to go through and complete the training. You may develop complications along the way. So you are asked to leave. And for prisoners, as they come in, they are taken through a medical screening the next day, because most of the time on the first day they come in late after 5 o'clock, and then they have to go through all of this procedure of entry into the prison. So there's no time. It's night by the time they are through with that. So very early the next day, we take them through a medical screening, and this involves HIV testing. And this is done on, it's not forced, it's voluntary. We counsel them and we offer the service. And mostly, almost 100% of them take up the testing because you see, most of the time they are first offenders, they are unstable, they are scared, they don't know what would happen to them. Unfortunately, we take advantage of this situation and give them a test. We also offer a routine HTC, including PITC, just like the normal ones, as recommended by Ministry of Health. We conduct HTC outreach activities to various prisons that do not have the capacity, they don't have the infrastructure, they don't have the health workers to do the service by themselves. And this is the major hindering factor. So we carry out outreaches to major prisons that have more than 500 prisoners as inmates. Then we also carry out biannual medical screening, mass screening, twice a year. And in this one, it's almost, I didn't say it is, I'm saying almost compulsory, because everybody has to come together and they have to get counseled. They have to accept, because you tell them the risks of harboring any one of them being positive and refusing to take the test and therefore refusing the treatment. Is a danger to everyone. So we work with them to make sure that even among themselves, they encourage each other to come and take the test. And obviously after the testing, we have the linkage to care. We have two types of linkages. We have one for prisoners and one for staff. So the one for prisoners, we have the referral from outreach points to accredited facilities. As we go to the outreaches, we have some prisoners tested and they are positive. We refer them to one of the 10 ART centers to continue treatment, and sometimes we take them to nearby community-based facilities where they are tested, and when they are found positive, then they are referred and taken to the treatment centers. We have referral from the prison to prison following transfers. This was quite a bit of a hitch, because as I said, most of the time the prisoners are transferred without appointment, meaning that they will not go with their notes, they will not get a referral. So when they go to the next point, they are retested and recounted and probably start all over again, if they are lucky. And there's time lost, and there's development of resistance, and all of so many other problems. So we have generated a referral strategy to make sure that wherever you are taken, we can know whether you've been on treatment or not, and which treatment, so that we can continue on treatment. And then there's a referral to public health care facilities on discharge from prison. This was also another one. You see, prisoners are fearful. When they are discharged, you don't want to go with a signpost saying, you see, you guys have been in prison, can I start accessing care from your facility? It's not possible. They hide. So we have come up with another strategy to make sure that as they leave prison, they're already linked to a community-based health care that will take them up after prison. And for staff, we refer them depending on where they've been posted. If they are posted at a facility with care, a prison facility with care, one of the 10, then we integrate them in that care. If they are referred to a facility which does not have care, then we refer them to the nearest community-based service for them to be cared for. This happens on transfer and on retirement. And then monitoring for treatment. I know I'm on time. We normally use regional hubs. We have established regional hubs. We have 16 regions in the country where they have put laboratories that can provide a lot of services, including monitoring. And we do viral load and gene expert and for MDR TB. We also use VHTs, that village health teams, to provide community tracing for referral. And we have introduced a computerized system on OpenMRS. That's what we use. It's internet-based. So wherever you go, we can access your data. If you have the access codes, I punch in your name and your prison number, then all of your file will come to me, so I can continue on treatment. And we can do this anywhere, wherever we are. And then we're also implementing DOTs to ensure that everybody takes their treatment when they are supposed to. On supplies, we all get the supplies from the main Ministry of Health. There are no problems there. Labs are monitored by the regional hubs and the national public health laboratories to ensure quality. And then service centers are supervised by CDC. We get funding from CDC. So on a quarterly basis, CDC comes to see what we are doing and offers quality control. And also the regions have quality control teams that go around to the lower level units. M&E, we conduct quarterly support supervision visits to give technical support. You have monthly and quarterly facility regional and country performance reports in the DHIS2, which we meet and review and evaluate. We also do studies to evaluate our performance. We have so far done one where we got this prevalence. We're in the process of doing another one to evaluate the referral and linkage strategy using the OpenMRS. The major challenges are poor infrastructure, understaffing, and lack of equipment. This cuts across the board, but it's more emphasized in the prison environment. We have inadequate supplies. Sometimes we run out of testing kits because of the big numbers, especially when we do mass HIV screening, the biannual. And then we have the attitude of prisoners getting services from the uniformed VHTs. So the VHTs are uniformed because those are the ones that we can maintain within the system. But this guy has been holding a gun at your back, now he turns around and says, I want to take your HIV test. You may have second thoughts. We have legal barriers, as we have already seen, under MSM. And we think that task shifting is a good strategy to go forward, using VHTs and community people to conduct the testing. We need to improve the infrastructure. We need to strengthen the monitoring aspect. And we need to improve the supply chain management. Thank you very much.